All right, we're on chapter 14 is talking about shock. So standard competencies are shock applies fundamental knowledge to provide basic and selective advanced emergency care and transportation based on assessment findings for a patient in shock, respiratory failure or arrest, cardiac failure or arrest, and post-resuscitation management. Pathophysiology of shock applies comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Shock is a state of collapse and failure of the cardiovascular system. Body attempts to maintain homeostasis in the early stages of shock, and then blood circulation slows and eventually ceases. All right, shock can occur because of medical or traumatic event, so you must be constantly alert to signs and symptoms of shock. All right. All right, the blood pressure is the cardiac output times systemic vascular resistance. The mean arterial pressure, the MAP, is generally considered the patient's blood pressure. So the MAP is usually diastolic blood pressure plus 1/3 of the pulse pressure. Autonomic nervous system controls the cardiovascular system, and it is a function, or control of the cardiovascular system is a function of the autonomic nervous system. The autonomic nervous system is primarily regulated from the upper part of the medulla oblongata of the brain. Okay, sympathetic nervous system prepares the body for physical activity during a stressful event, and then the parasympathetic nervous system is primarily responsible for rest and regeneration. All right. So the physiology of perfusion. You can see the pupils dilate, the arterioles, the arteries constrict, the lungs, bronchial muscle relaxation, GI tract is flowing, the heart rate's increased, force of contractions increase, and then the increased conduction speed. Okay. The sympathetic nervous system is on your left. Okay. The parasympathetic is your resting. So pupils constrict, arteries not affected, the lungs not affected. GI tract is increased elevation and increased motility. The heart decreases the rate, decreased contractility, and decreased conduction speed. Um, Physiology of perfusion. Your sphincters regulate blood flow through the capillary beds um, under the control of the autonomic nervous system. Regulation of blood flow is determined by cellular need and is accomplished by vessel constriction dilation. Maintenance of perfusion or maintenance of the blood flow is accomplished by the heart, blood vessels, and the blood working together. All right, respiration and oxygenation. For each breath, the alveoli receive a supply of oxygen-rich air. Oxygenated blood passes through the alveolar wall into the pulmonary capillaries. If oxygenated blood is not properly circulated, cellular death may result. Diffusion is a passive process in which molecules move from an area of higher concentration of molecules into an area of lower concentration. The oxygen molecules move from the alveoli into the blood. Carbonic acid breaks down into the lungs, and carbon dioxide is exhaled. Maintains the delicate balance between gases and maintains the pH of the blood. So, what can shock result from? Shock can result from inadequate cardiac output, decreased systemic vascular resistance, or the inability of red blood cells to deliver oxygen to the tissues. So, if shock does persist, it will ultimately result in death of the entire organism. Okay, the body attempts to compensate by shutting blood flow from the organs, more tolerant of low flow, such as the skin, the testes, etc., to the vital organs itself, the heart, the brain, the lungs, etc. So the body's going to basically shut down the peripheral, and it's going to move into the more anterior, more important organs that are actually needed. So this graph shows the heart itself pumping. So there's three parts of it: set of pipes, blood vessels, or the arteries that act as the container and contents of the blood, fluid or the blood. So the perfusion triangle, the heart, damage to the heart by the disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. The blood vessels, container function. If all the blood vessels dilate rapidly, the normal amount of blood volume is not enough to fill the system and provide adequate perfusion to the body. And then the blood itself, the content. If there's enough blood and plasma lost, the volume of the fluid of the container is not enough to support the perfusion needs of the body. So, blood is the vehicle for carrying oxygen and nutrients. It contains the red blood cells, the white blood cells, the platelets, and the plasma. Blood clots control blood loss, and they form dependent on retention of the blood because of blockage in the blood circulation, the changes in the vessel wall or a wound, and the blood's ability to clot as a result of disease process or medication. So, when injury occurs, platelets begin to aggregate at the site of the injury. So they're going to go to the site, the platelets will. This causes the red blood cells to become sticky and clump together. As the red blood cells begin to clump, fibrogen reinforces the red blood cells. So clots can become unstable and susceptible to rupture. Right, the body's neural and hormonal mechanisms are triggered when the body senses that pressure in the system is falling. The sympathetic nervous system will assume more control of the body's functions during a state of shock. The parasympathetic nervous system controls the voluntary functions by sending signals to the cardiac, smooth, and glandular muscles and takes over during non-stressful situations. Okay? So basically, the sympathetic nervous system it controls your body's functions during that fight or flight. Also, a shift in the body fluids may help to help maintain blood pressure within the system. All right, compensation for decreased perfusion. Baroreceptors decrease blood pressure and flow and activate vasomotor center in the medulla oblongata to increase blood pressure. Chemoreceptors measure suitable shift in amounts of carbon dioxide in the arterial wall or the arterial blood. So stimulation occurs when the systolic blood pressure is between 60 and 80 in adults or even lower in children. All right, so in response to the hyperperfusion, the renin, angiotensin, basically the RAA system in the kidneys is activated and antidiuretic hormone is released from the pituitary gland. So this results in an increase in the blood pressure and maintenance of cardiac output. So overall response is of the initial compensatory mechanism is to increase the preload, stroke volume, pulse rate, which results in an increase in cardiac output. So autotransfusion effect, along with the subtle effects of other response systems of the body, allows the body to compensate adequately for a volume loss of up to 25%. If hyperperfusion persists, myocardial function worsens with decreased cardiac output and ejection fraction. Tissue perfusion decreases. Fluid may leak from the blood vessels, causing systemic pulmonary edema. As the patient decompensates, perfusion to the brain and coronary arteries decrease. Cells switch from aerobic to anaerobic metabolism. So remember, aerobics with oxygen and anaerobics without oxygen. So anaerobic metabolism, a cellular process occurs in the absence of oxygen. Aerobic metabolism, all cell processes occur with the oxygen supply. So then the body produces epinephrine and norepinephrine in the adrenal glands in response to hypoperfusion. So, planned shunting of the blood from areas of lesser need to areas of greater need is referred to as the pecking order. Golden hour or golden period. So this is where the golden hour is really important as far as getting these patients on the low heart table. So failure of the compensatory mechanism to preserve perfusion results in decrease in preload and cardiac output. All right, shock-related events at capillary and microcirculatory levels has perfusion decreases, cellular ischemia can occur. It's actually decreased oxygenation of the cells can quickly result in metabolic acidosis. So anaerobic metabolism results in systemic acidosis and depletion of the body's normal high energy reserves. Incomplete glucose breakdown results in accumulation of pyruvic acid. So ischemia stimulates increased carbon dioxide production by the tissues. Acidosis serves as an indirect measure of tissue perfusion, and this reduced levels of ATP results in dysfunctional sodium-potassium pump. So your ATP can't help your negative and positive pump balance out. All right, cellular flooding explodes the lysosomal membrane and releases lysosomal enzymes. Lysosomal enzymes also digest the cell, leading to organ failure, reduces blood supply to vasomotor center in the brain, results in slowing and stopping the sympathetic nervous system activity. So continuing buildup of lactic acid and carbon dioxide acts as a potent vasodilator. In conjunction with all the injury occurring, the white blood cells and blood clotting system are impaired. Disseminated intravascular coagulation may occur. DSC is been found to complicate septic shock. So, MODS, progressive condition characterized by combined failure of several organs, major causes of death following septic, traumatic, and burn injuries is MODS. It occurs when injury or infection results in the release of numerous inflammatory mediators and activation of the complement system, the coagulation system, that's your clotting system, and then your kinase system. So this typically develops within hours to days following the resuscitation, and it can be hard to treat. So signs and symptoms include hypertension, insufficient tissue perfusion, uncontrolled bleeding, multi-system organ failure caused by hypoxia, tissue acidosis, and severe local alteration, metabolism. All right, respiratory insufficiency. Insufficient concentration of oxygen in the blood can produce shock, has vascular causes. Without oxygen, organs in the body cannot survive, basically. So certain types of poison may affect the ability of the cells to metabolize or carry oxygen. Carbon monoxide poisoning, and also cyanide poisoning. And this is why we tell you do not trust your machines, your pulse oximeters. Anemia is defined as an abnormal low number of red blood cells, and it may be the result of either chronic or acute bleeding in severe tissues, may be hypoxic. So expect shock if a patient has multiple severe fractures, abdominal or chest trauma, spinal injuries, severe infection, major heart attacks, and anaphylaxis. So there's types of shock or hypovolemic shock due to inadequate blood volume. Hypovolemia is the from blood or fluid loss in a common culprit. So there's so hypovolemic shock. We always say shock is due to inadequate blood volume. Hemorrhagic and non-hemorrhagic causes of hypovolemic shock. Non-hemorrhagic shock occurs when the fluid loss is contained within the body. So, all right, abnormal losses of fluids and electrolytes, dehydration, may occur through gastrointestinal losses, vomiting, diarrhea, especially a lot. And it really is going to depend also how much that person can tolerate loss of. Increased loss as a result of a fever, hyperventilation, or high environmental temperatures. Increased or excessive sweating. Internal loss has peritonitis, pancreatitis, and ileus. Plasma losses from burns, drains, and granulating wounds. Some other causes could include ascites, diabetes insipidus, and osmotic diuresis, secondary to hyperosmolar state. Early signs of shock and restlessness and anxiety. So if conscious, the patient may report being thirsty, skin can become pale, cool, and clammy, and the heart rate speeds up. And, I've seen this in the summertime also. You go to a patient that hasn't been outside in the air conditioning a lot. and they're talking about they're thirsty. So we'll talk about this more later on in later chapters. But that thirst thing is a sure sign sometimes of what's fixing to happen. Certain symptoms of dehydration include loss of appetite, nausea, vomiting, and sometimes fainting. So as bleeding or fluid loss continues, the blood pressure finally fails in the shock patient. Do not wait till the blood pressure falls before you suspect shock and begin treatment. So the goal in treating shock is to save the brain, lungs, and the kidneys, and that's your major organ. All right, cardiogenic shock is usually an inadequate function of the heart, the pump failure. So edema, presence of abnormally large fluid, amounts of fluid between cells in the body tissues. Pulmonary edema results in impaired ventilation for whatever reason. For blood to circulate efficiently, there must be the right amount of pressure and an adequate number of heartbeats. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. Obstructive shock results in conditions that may cause obstruction of cardiac muscle, also affect pump function. So cardiac tamponade occurs when blood leaks into the pericardium itself. Tension pneumothorax is caused by damage to the lung tissue. Heart and respiratory rate increases, becomes shallower, and blood pressure decreases. A pulmonary embolism, a blood clot that occurs in the pulmonary circulation, can prevent blood from being pumped from the right side of the heart to the left. Distributive shock results when there is widespread dilation of the small arterioles and small venules, or both. Septic shock occurs as a result of a severe infection. It's usually bacterial in nature. Toxins damage the vessel walls, causing increased cellular permeability, and this presents with similar to hemorrhagic shock, that weak 30 pulse, that shallow rapid respiration, autonomic status, and warming heart. Neurogenic shock results from due to damage to the nervous system that controls the size and muscular tone of the blood vessels. So muscles in the walls of the blood vessels are cut off from the sympathetic nervous system and nerve impulses that cause them to contract. All these vessels below the level of the spinal injury dilate wildly, increasing the size and the capacity of the vascular system. Characteristics and signs: absence of sweating below the level of injury, normal warm skin, and lack of an elevated pulse. That's neurogenic shock. And we'll talk about this more later also, because of these signs and symptoms are kind of different than normal shock. Anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. So there's no loss of blood, no mechanical failure damage, and only a slight possibility of direct cardiovascular injury. Results in widespread vascular dilation, increased permeability, and bronchoconstriction. Instances that cause severe allergic reaction include injections, ingestion, and inhalation. It can develop within minutes or even seconds after contact with a substance to which the patient is allergic. Cyanosis is late sign of anaphylactic shock. The psychogenic shock is a sudden reaction of the nervous system that produces a temporary generalized vascular dilation, resulting in fainting or syncope. Causes of syncope that are potentially life-threatening result in the events such as irregular heartbeat and brain. So the progression of shock is usually there's compensated shock first, and then there's decompensated shock. So compensated shock is the early stage of shock, while the body can still compensate for blood loss. Decompensated shock is the late stage when blood pressure is falling. And you'll get behind the 8 ball with decompensated. So irreversible shock is shock that has progressed to a terminal stage. Compensated shock at this stage, the level of responsiveness is a better indicator of tissue perfusion than most other vital signs. Chemical mediators are released by the autonomic nervous system. This increases the rate and depth of respiration. Blood pressure is maintained. It stays pretty normal. There's a narrowing of blood pressure, pulse pressure. So the blood pulse pressure is your systolic pressure minus your diastolic pressure. Those numbers keep getting closer and closer when you're taking that manual blood pressure. So patients may have a positive orthostatic vital signs. We'll talk about orthostatic. But that's basically where you're laying flat. You can sit up and then you stand up and you have a certain degree of changes in your blood pressure and your pulses also. And this is a sign of symptom of dehydration of some sort. So treatment at this stage is typically does result in recovery. So most people do. All right, decompensated shock, you start to get behind the 8 ball kind of quick. Blood pressure falls, blood volume decreases more than 30%. Compensatory mechanisms begin to fall, and signs and symptoms are much more obvious. Cardiac output falls dramatically. Vasoconstrictions can have a disastrous effect if allowed to continue to fall. Treatment at this stage will sometimes result in recovery, so you can recover from this, but it will take a little bit longer. Irreversible short arterial blood pressure is abnormally low. A rapid deterioration of the cardiovascular system occurs that cannot be reversed. Life-threatening reductions in cardiac output, blood pressure, and tissue perfusion. Distinction between decompensated shock and irreversible shock is based on the failure of the shock state to reverse with appropriate treatment. So, it can be very hard to distinguish between irreversible shock and severe decompensated shock in the pre-hospital environment due to we're not looking at all the blood values. We're not looking at, is the pH good, and different things like that. So we're going to treat these patients aggressively. We'll talk about that. But we usually hope that, they can recover from these things. So patient assessment, look for and address hazards and threats to the safety of the crew, bystanders, and the patient itself. Put several pairs of gloves in your pocket for easy access. Observe the scene and patient for clues to determine the nature of the illness and the mechanism of injury. The more traumatic injuries a patient has sustained, the less likely the patient will be able to compensate. Primary survey, perform a rapid full body scan of the patient to determine LFC. Identify and manage life-threatening concerns. Determine the priority of patient transport. Threats to circulation, airway, breathing are considered life-threatening and must be treated immediately. So, remember that CAB. Even with your CPR now, remember CAB. Try to threaten those major bleeders. Does this patient need high flow too? And whatever, what else? Do they need assisted ventilation? Made that via with an airway adjunct, different things like that. All right, so life-threatening bleeding should be treated first. Direct pressure. If it's a big bleeder, go ahead and put your tourniquets on. So observe the patient for signs of accessory muscle use. Increased respiratory rates, often an early sign of impending shock. Assess the patient's circulatory status. Check for the presence of a distal pulse. Check your radials. Check your pedals. A rapid pulse should suggest compensated shock, and maintain a high index of suspension for occult injuries. All right, if the patient shows signs of hyperperfusion, gain IV access quickly. Large bore, treat aggressively, provide rapid transport. Administer fluid en route. I would say, administer all this stuff en route. Even an IV can be done en route. Do not delay transport to complete non-life-saving treatments. Instead, perform these treatments en route. Okay, and I'm going to get on this, and you'll hear me say this over and over and over. These trauma patients, these shock patients, even if it's cardiovascular distributive shock, you need to treat them like trauma patients. We're giving you 10 minutes on scene with these patients. Get them loaded up, do the quick primary assessment, look at your CABs, treat those really quick, and then get on the road. Okay, do not delay transport. So, history taken. Determine the chief complaint. Obtain a medical history and be alert for injuries to specific signs and symptoms. Quickly obtain your sample. If you can from the patient, not get it from somebody else. If the patient or look for clues on the same. If the patient experiences a substantial change in LSD before arrival at the hospital, provide the hospital personnel with this important information. So blood thinners can make bleeding injury considerably worse as far as your CAB. Secondary assessment, repeat your primary. Start with full body exam to be sure that you identify the injuries. Treat life-threatening problems immediately. Obtain a complete set of vital signs. If the patient condition is unstable, reassess vital signs every 5 minutes. If the patient begins to stable out, reassess vital signs every 10 to 15 minutes. So use monitoring devices to quantify the patient's oxygenation and circulatory status. Use the pulse ox to evaluate the effectiveness of oxygenation. Use a manual technique to monitor your blood pressure first, and then, of course, you can go to the non-invasive technique. Also use that glucometer to monitor glucose levels. All right, reassessment determines if the interventions performed are having any effect on the patient. Determine if the interventions needed for your patient at this point based on the findings. So they focus on supporting the cardiovascular system. Treating for shock early and aggressively will help to prevent inadequate perfusion from harming your patient. So patients who are decompensated shock need rapid intervention to restore adequate. All right. So treatment for shock begins in the assessment process. Control all obvious external bleeding. Place the patient in a position dictated by local protocols for shock patients, and this is going to be the Trundle bug position here locally. So provide warmth, gain IV access, and administer fluid. So the golden hour is for 60 minutes after the injury. This is where you want these patients sitting on the operating table or wherever this corrective action can take place. You can that thirsty sign that we talk about from these patients. Don't forget about it. You can take you can take a moistened gauze, washcloth, anything that's sterile with sterile water or sodium chloride if you have that on the back of your hands too. Let them stuck on it. As long as they're not drinking massive amounts of water, they can at least stuck on that. So it's just a little point. So initial management for shock, manage airway, administer stuff in the too. Manage that airway however you need to manage it. Okay. Like I said before, if you don't have an airway, you don't have a patient a lot of times. So get those vital signs. Get that IV IO access if you need it. A lot of times with shock patients, veins are going to collapse. You may not be able to get that large bore. If you can get those small gauge IVs, try it. However, you may have to go straight and get that IO also. So maintain the body heat. All right, IV lines. They're inserted to provide a route for immediate replacement fluid in the patient. So a route for potential replacement in patients who are at risk for losing substantial volumes of fluid or blood. Also a route for medication. All patients in hypovolemic shock need IV fluid replacement. So in case of the need for emergency administration of medications, IV lines should be inserted TKO, and that's to keep the vein open. Most protocols do advise administration of IV fluids on boluses of 20 mL per kilogram, up to 30 mL per kilogram in the 250 to 500 mL increments until radial pulses return. If the vital signs return within normal limits, follow the IV fluid administration to a TKO rate and reassess frequently. Call early for paramedic intervention to administer vasopressors if needed. So basically, you basically want to get that blood pressure up and get pulses back, especially radial pulses with these shock patients. A lot of times it's going to be around the 80 to 90 systolic range, and that's sort of where you want to keep it. So, once you start administering that fluid, you're going to have to reassess these patients every 5 minutes, then 10 minutes, and then 15 minutes. And sometimes you will get that pulse back, that blood pressure back, and you'll get it high enough, around that 90 mark. Don't forget, we try to keep it around that mark. because we don't want to replace fluids completely to the red blood cells and the hemoglobin, the oxygen carrying capacity of the body. So we still want blood circulating in there. We've controlled his hemorrhage hopefully somehow, and then we got some fluid back coming back in there to help fill those pipes, not completely take over the blood itself, what's left inside the body. Because if the body still can, it's still producing that blood, those red blood cells. Okay. So also don't call for your paramedic. We do have pressures that we can give if needed. And basically a pressure is help elevate the blood pressure quicker. All right, special consideration of fluid resuscitation, for instance, when increasing blood pressure may be detrimental to the patient, it's necessary to administer only enough fluid to maintain radial pulse. Okay. It can increase the workload on the heart, worsening cardiogenic shock, and increasing internal bleeding. Temperature control is vital, maintaining perfusion in children and infants. Don't forget about your Borzoi tapes or other reference to remember normal vital signs by age in pediatrics. So carefully monitor the patient's status and treat conservatively in instance of uncontrolled hemorrhage. Patients who have a chronic hypertension may require a higher blood pressure to achieve the same level of in-organ perfusion. And the only way to maintain fetal perfusion is to aggressively treat the mother. So place the pregnant mothers on the left lateral recumbent position if they are in shock. This is going to get pressure off the vena cava that helps treat both the mother and treat the child too. All right, treating hypovolemic shock, control all obvious pictorial bleeding, en route to the ED, establish at least the 18 gauge or larger. Recognize internal bleeding, provide aggressive general support, secure and maintain an airway, provide restorative support. Don't give the patient anything by mouth, because a lot of times the patient will end up in surgery. So monitor mental status, pulse rate, blood pressure, and provide rapid transport to the closest, most appropriate facility. Cardiogenic shock. Before you administer nitro, be sure the systolic blood pressure is greater than 90 and consult with medical control. Assess the blood pressures manually and gain IV access prior to nitro administration. Always do your first one manual. That way, when you do a non-invasive blood pressure, you can make sure that it is correct. Because if it is not, you're going to cause some problems. Okay, place patient in a position of comfort and administer high flow 2. Provide prompt transport to the ED and a facility of appropriate care. Get your IV access, administer fluid at a TKO rate, and frequently check for pulse and unresponsive patient to identify whether an automated external defibrillator is needed. So, the only treatment available in the pre-hospital providers is early recognition and rapid transport. Tension pneumo, high flow 2, non-rebreather, 15 liters, provide decompression of the injured side of the chest. So this is done by needle chest decompression, and this is at the permanent level in the state of North Carolina. So however you need to keep that in the back of your head, that this is what these patients need. So gain IV access, has a medication route and administer fluid at a TKO. It says make sure that you assess the body heat and conserve it, because of the vasodilation. It's going to open up a lot of the pipe, and this is going to cause coldness. All right, neurogenic shock. Anaphylaxis. Administer epinephrine by way of subcutaneous or intramuscular injection. Okay. Anaphylactic shock, always remember, you should have learned this with your basic, is the respiratory component of allergic reaction. That's when you're going to get this epinephrine. Okay, you need to be careful with it. Don't forget about special considerations with ages and history, especially cardiac history. Your pediatric patients also. So a patient is aware of having specific sensitivity may carry a bee sting kit containing epinephrine. So basically an EpiPen. Okay, patient signs and symptoms recur or the patient condition deteriorates, repeat the injection after consulting with medical control. Promptly transport this patient to the ED by providing all possible support and try to determine what agent caused the reaction and how it was received. Keep in mind that a mild reaction may worsen and gain IV access has a medication route and administer fluid TKO. So, basically, Epi 1 to 1, Epi 1 to 1,000, make sure you do that concentration. Make sure you know your dosages. Also, Benadryl may be needed with the entry part and the release of the histamine. Psychogenic shock can substantially worse than the other types of shock. Record your initial observations of vital signs and level of consciousness. Try to learn from bystanders whether the patient reported any problems for fainting or how long he or she was unresponsive. So respiratory insufficiency, immediately instill any hole in the chest, stabilize impel objects in the chest, secure and maintain the airway, and administer supplemental O2. So you got a hole in the chest, do your three-sided occlusive dressings. Got an impel object, stabilize it the best you can. Don't forget about the minimal movement of the patient itself so that object don't move inside. So then high flow to or supplemental oxygen, however you need to. Non-rebreather, nasal cannula, or if you have to, actually intubate these patients. Clear the mouth and throat of any obstructions, determine the need for assisted ventilations with oxygen, supplemental oxygen, and determine the most appropriate transportation destination based on the patient's condition and local protocol. So, are you going to be able to transport this patient by ground? If your truck is at the highest level, is the advanced EMT level, don't forget about that paramedic intercept if needed. Or if you need to, if you got a long transport to a trauma center, you may need that air medical support also. And this is the end of chapter 14 and the types of shock. So just remember with shock, it is insufficient. Insufficient oxygenation of the blood cells itself. So that's what we're trying to get back to, and the different ways you to do it. That high flow to don't replace a lot of fluids, with the red blood cells that are in the blood that's circulating already. So basically, we don't want to see clear fluid coming out of holes that are already established for some reason. Maintain those radial pulses. Maintain that blood pressure maybe around 90. Have large bore IVs, maybe 2 if needed. Different things like that. Your anaphylaxis patients, don't forget about that. That respiratory component before you give them the AP 1 to 1,000. So different things like that. Sepsis is going to need fluid. Septic shock. So also don't forget, if you need those vasopressors, get your paramedics around. Respiratory shock with the tension pneumothorax is to get your paramedics around. That chest decompression is the thing that's going to fix that. So, all right. So, overwhelming infection, all different kinds of shock. So once again, we got the pump failure here. Causes a heart attack, um, trauma to the heart, um, obstructive causes could be large pulmonary embolism. So low fluid volume causes could be trauma to the vessel itself. Um, Fluid loss from gastrointestinal tract, such things as vomiting and diarrhea can also cause the fluid component of the blood. So also poor vessel function, infection, drug overdose, such as a necrotic, spinal cord injury, and anaphylaxis.